Good afternoon, everybody. Welcome to the breakout session on building the bridge, innovations in monitoring, care management, and support. I'm Marcus Plescia. I'm the Chief Medical Officer for the Association of State and Territorial Health Officials, and I'll be moderating the Q&A in this session after we have the presentations. And just as we kick off, I'm going to very briefly introduce our three panelists. You actually, on the dashboard, if you pull up the session, their names are highlighted, and if you click on their names, you can get a much more detailed bio of them. I'm just going to very briefly give an overview of each of the people who will be on the panel. The first presenter will be Lisa Bari. She is the interim Chief Executive Officer at the Strategic HIE Collaboration, the Strategic Health Information Exchange Collaboration. And you'll see from Lisa's bio that she has extensive experience in health information technology, most recently at the Centers for Medicare and Medicaid Services. The second presenter will be Dr. Robert Harmon, who is the Senior Physician Executive for Cerner Governmental Services. He has a wide range of experience that you'll see in his bio as well. Most recently, some interesting public health experience when he was the director in the Florida Department of Health in Duval County, which is in Jacksonville, Florida. And then the third panelist will be Mylynn Tufte, who leads Optum Healthcare's Strategy Population Health Management practice. And she too has former public health experience as the most recent state health official in the state of North Dakota. So we are very pleased to have such a excellent group of panelists, and I'm sure you'll enjoy their presentations. And we'll look forward to having some in-person Q&A with them at the end of those sessions.
Hello, my name is Lisa Bari, and I'm here representing the Strategic Health Information Exchange Collaborative. And I'm happy to be at the ASTHO COVID-19 Tech Expo in the Building the Bridge session. I'm here to talk about how America's HIEs are supporting the COVID-19 public health response. And just quickly about SHIEC and HIEs, SHIEC is a national collaborative representing more than 81 health information exchanges. And our member HIEs serve greater than 92% of the US population. Our HIEs are nonprofit, vendor neutral, multi-stakeholder governance model HIEs, and many are state designated entities or quasi-governmental organizations. And each member HIE provides services within specific states and geographic areas. And by providing enhanced access to all available and relevant patient data and creating longitudinal patient record, our HIE members aim to improve the quality, coordination, and cost effectiveness of healthcare provided in their communities. Our member HIEs are experts in patient matching, data quality, and incorporating expanded data sets, such as social determinants of health and claims data into clinical data sets. More and more, you'll see HIEs becoming broader ranging health data organizations, and they generally represent the needs and the preferences of their local, regional, and statewide healthcare communities. Just really quickly to give you a sense of where our members are, they're across the entire country. They're in 46 states, and they reach 92% of the US population. So for today's presentation, I want to talk briefly about three areas that HIEs are broadly involved and give you examples in each of those areas across different HIE members across the country. So first is lab reporting, case investigations, contact tracing, and syndromic surveillance, and then vaccine distribution administration, and finally, hospital capacity and supply management. So first area, pretty broad area, lab reporting, case investigations, contact tracing, and syndromic surveillance. The first example is about electronic lab reporting and electronic case reporting. Broadly speaking, expanding existing data sharing capabilities for public health reporting for ELR and ECR, informing public health and states' data-informed response and decision-making in the COVID-19 pandemic. One great example we have is from North Dakota. The North Dakota Health Information Network has been working with the state and their health lab to minimize paper forms to help collect data for mandated public health reporting, including ELR, syndromic surveillance, immunization data with a bidirectional query to provider EHRs, and electronic test and order results to the state's public health lab. The second category, this is also a really big one, is data quality and completeness, really important for HIEs. And broadly speaking, this is improving notifiable conditions reporting and improving data quality and data completeness. A great example here is from Health Share Exchange in Philadelphia. They're helping the Department of Health in identifying missing information about hospitalizations, deaths, and race and ethnicity demographic data. The next one is, in some places, this is true, that HIEs are centralized public health reporting services. So this would be broadly serving as a centralized reporting service for lab test results reporting and additional data types to improve reporting burdens for healthcare facilities, providers, and labs. Obviously, a very big theme in the COVID-19 pandemic so far is massive reporting burden from providers. And last year, Nebraska's Department of Health and Human Services requested that all healthcare facilities, healthcare providers, and labs connect to NEHI, which is now known as Sync Health, to send admissions, discharge, and transfer files, labs, and syndromic surveillance information, including data captured within ambulatory settings. And in line with that, the next category, of course, is syndromic surveillance. Broadly speaking, supporting symptom reporting through surveillance data feeds from hospitals, urgent care, and other healthcare settings to enhance situational awareness or preparedness. And in Alaska, the Department of Health and Social Services syndromic surveillance data comes to the section of epidemiology in the state via Healthy Connect, Alaska's Health Information Exchange. And this hospital emergency department visit data is automatically collected, sent to the analysis program, and processed for the epidemiologist in the state to review. And then finally, in this category, we have alerts and notification. So broadly enhancing contact tracing capabilities with up-to-date contact information from recent healthcare encounters that was captured and routing these notifications to care teams. An example here is from HealthX, an HIE in New York, which is delivering millions of COVID-19 alerts to clinicians, care managers, and providers. Okay, next big category and very important one these days is vaccine distribution administration. So first category is increasing vaccine administration reporting to public health jurisdictions. CRISP, the HIE in Maryland and DC, they make COVID-19 immunization status available to clinicians and public health, and they display those immunization results in multiple places, such as care alerts, an immunization widget, and an encounter notification system prompt. This information available includes manufacturer, date, and place administered. The next group here is identifying priority populations with specific multiple comorbid medical conditions for vaccine administration for phasing and outreach efforts. And again, CRISP in Maryland and DC makes it a COVID vulnerability index available, which allows public health and providers to identify high-risk patients for outreach. The next group here is serving as a designated method for vaccine administration reporting by facilitating data sharing from healthcare settings. In North Carolina, the State Designated Health Information Exchange, NC Health Connects, is offering this kind of connectivity and patient matching across sources to really enhance the vaccine data available by utilizing their master patient index. And they receive the administration data from points of care such as CVS, Walgreens, hospitals, health systems, and EHRs. And then finally here, broadly speaking, identifying vaccine status for Medicaid or specific payer populations. And in Kentucky, Kentucky's Health Information Exchange has created an immunization information dashboard focused on adolescent and pregnant women and Medicaid as a tool for providers and other stakeholders. And then finally on our list is hospital capacity and supply management. So this means for us tracking and disseminating real-time hospital volumes and resource utilization. Health Current in Arizona, the statewide HIE, leveraged their existing admission, discharge, and transfer data. They're already connected to the majority of hospitals in the state to supply real-time bed capacity data to the Arizona Surge Line, which was a 24/7 statewide phone line developed by the Arizona Department of Health Services for hospitals and other providers to call when they had a COVID-19 patient needed a level of care they could not provide. So I hope you can see that there are lots of areas that HIEs across the country are getting involved in their response to the pandemic. And you can see as well that there's each of these solutions is specific to the local, regional, or statewide healthcare community and their needs. And that's what's really important to HIEs who are members of SHEIC, and that's what we're hoping to talk about today. Thank you again. My name is Lisa Berry, representing SHEIC, and I'm happy to be here with everyone for this panel.
This is Dr. Bob Harmon, recording Cerner's response to the COVID-19 pandemic for the ASTHO Tech Expo. I want to thank ASTHO for sponsoring this event. It gives me the opportunity to speak about two subjects that I care about deeply, public health and health IT. I'll speak from the perspective of a large global health IT company responding to one of the worst pandemics and public health emergencies of the past century. I'll first describe Cerner's initial response to support our clients, associates, and partners in the private and public sectors. I'll then talk about the many recovery activities that are underway, followed by the next steps that Cerner believes are critical to prevent and control future emergencies like the COVID-19 pandemic. We should remember that all hazards, including storms, floods, wars, and other catastrophes, must be considered in our plans. We must also remember that modern, reliable, and secure IT systems are a critical component of emergency preparedness. Regarding response, when the pandemic emergency was declared, Cerner established an emergency incident command structure, a team, and a virtual COVID-19 client forum. These groups met frequently and soon produced client pandemic guides for prevention, testing, treatment, surge capacity, telehealth, reporting, analytics, research, regulatory requirements, financial services, and vaccination planning. We've produced similar pandemic guidance for our more than 27,000 global associates in more than 30 countries. I should note that the vast majority of Cerner associates have been working from home since March of 2020. Our associates work with client partners to create new electronic health record tools such as alerts, clinical decision support rules, electronic templates and forms, order sets, care pathways, quick visits, dynamic work lists and registries, and a COVID-19 electronic summary document called a CCDA for referral or Health Information Exchange, or HIE. We're committed, by the way, to nationwide interoperability via the Commonwealth Health Alliance and its links with care quality and state and local health information exchanges. Patient communications were enhanced by a new content and tools in our Healthy Life patient portal. Client telehealth services saw a big increase, including a hospital at home solution, virtual video inpatient communications, an expanded partnership with American Well, and a wide array of new digital self-service options. Regarding recovery, we expanded a large-scale mass vaccination solution that's now used by more than 170 clients. Also, on February 5th, we began holding a series of large mass vaccination events at our world headquarters in North Kansas City. The first event vaccinated more than 2,300 people. We also installed our EHR in temporary emergency hospitals, including in Britain and Spain. We've assisted our clients with COVID-19 reporting requirements to state public health agencies, the CDC National Healthcare Safety Network, and the DHHS teletracking and protect systems. Our associates are currently working with our clients to develop a more automated, real-time reporting capability for the steadily increasing number of data elements required by HHS from various provider systems. Our three major platforms, the Millennium Electronic Health Record, Healthy Intent Big Data, and CareAware Device Connectivity, are all involved. Also, to assist the CDC, we created a free Healthy Intent Enterprise Data Warehouse for reporting and analyzing Cerner client COVID de-identified electronic lab and syndromic surveillance data. Regarding what's next, Cerner is participating in the new Vaccination Credential Initiative Coalition, which aims to give individuals digital access to their COVID-19 vaccination records by way of a smartphone app with a QR code called a barcode. Testing of the new solution is expected this spring, with availability perhaps in the fall. Next, we're very supportive of CDC data modernization which is now underway with COVID-19 related funding. Cerner recommendations, which were submitted to the CDC in April 2020, included the following. Remove data silos and connect the more than 100 different surveillance systems, starting with the CDC's highest priorities, like electronic case reporting, or ECR, by way of a single national platform with modern standards, requirements, and interoperability. Also, reduce manual data acquisition costs and burden on providers. Also, enable real-time powerful analyses and policy making. Next, perform predictive analytics through machine learning. Next, turn research into action more rapidly. Also, simultaneously route personal identified data to the states and de-identified data to the CDC. Finally, assure that the platform and solutions are cloud-based and FHIR FHIR enabled. Regarding electronic case reporting, Cerner and I have been participating in the Digital Bridge Initiative since its beginning in 2016. This coalition launched its first successful pilot projects in 2018, including at Cerner client Intermountain Healthcare and the Utah Department of Health. Because of the pandemic, a COVID-19 rapid deployment project called ECR Now was launched last year. By the end of December, more than 6,500 facilities at 58 provider sites in all 50 states plus DC were using ECR. Cerner is now working with the CDC and Association of Public Health Labs to complete the development and a go live this month of a new ECR Now Fire app at our client Lawrence Memorial Health and the Kansas Department of Health and Environment. In conclusion, we now have new leadership in the White House, the US Senate, DHHS, and the CDC. It's a new opportunity to pursue public health data modernization and control of the current and future pandemics. We have lots of hard work to do. For more information, please contact me at bob.harmon@cerner.com or visit cerner.com. Thank you.
My name is Mylynn Tufte. I served as the State Health Officer for North Dakota for 3.5 years, starting in February of 2017 through the beginning of the pandemic until the end of May of 2020. My passion has always been making a difference in the health and well-being of individuals and populations. I get to do that now at Optum, where I'm the Population Health Practice Lead for Strategy and Growth. At Optum, we're dedicated to helping people live healthier lives and making the health system work better for everyone. We deliver simple, effective, and comprehensive solutions to organizations and consumers across the whole health system by integrating our competencies of data and analytics, clinical expertise, embedded technology, and consumer experience into all Optum services. On behalf of Optum, and from me personally, please accept our gratitude for your service, dedication, and strength throughout this unprecedented pandemic response. You are heroes to us. Optum is a part of United Health Group. This includes United Healthcare and our other sister entities. We have been helping communities and leading throughout these challenging times in many ways. We've been giving back to communities through funding in our COVID relief recovery efforts, and we've given $50 million nationally as well as $10 million internationally. This funding has been used to protect and support healthcare workers, address isolation among seniors, and support people experiencing food insecurity and homelessness. We're providing operational support, applying clinical expertise and innovation. For example, we helped pioneer a non-invasive, self-administered COVID-19 test method that streamlined the testing process and reduced PPE usage. We continue to support communities and members with access to care and tools to manage stress during this time. Currently, Optum works in 35 states, providing a variety of health and human service programs. We know that health is not just the care provided by healthcare providers. Health is dependent on the communities we live, work, and play, and the social supports that give us meaning and hope. We are working to address health inequities and bias throughout the system. I'm going to highlight a few examples of the work we're doing to support states responding to the COVID-19 pandemic. In West Virginia, Indiana, and another state where we're providing COVID-19 testing data that's enabled an equitable response and increased trust with citizens. When the COVID-19 crisis hit, Optum partnered with the West Virginia Department of Health and Human Resources. We provided support and an integrated eligibility system that processes benefits for medical coverage, food, and housing assistance. This scalable system was able to extend critical benefits quickly in response to policy changes. For example, within 72 hours, Medicaid and CHIP benefits were extended to more than 77,000 recipients. The eligibility system is critical to make sure West Virginians can get the help they need promptly. In Indiana, we've supported the State Offices of Medicaid Policy and Planning, OMMP, with data warehousing and analytic services for years. About a year before the pandemic, we were selected to help improve the data governance of their analytics system with the goal of democratizing the data and allow access to many other agencies as needed. This new framework launched right before the pandemic, and it supports interoperability and enabled agencies and individuals to access the data. With the new data governance and processes in place, state agencies, especially public health, were able to better monitor testing by using these existing systems. They also provided an accurate daily dashboard, empowering state health leaders to understand the data and make real-time strategic adjustments to respond. Our last example comes from another state that experienced similar challenges scaling systems to support increased testing needs in response to the pandemic. Optum was selected to take the load off the current overburdened system and accommodate for current and future testing growth. This fully automated system and approach provides highly reliable data and a repeatable process that enables better reporting and tracking, including addressing inequities that were exposed by the pandemic. The result is a strategic system that helped to unify state and local jurisdictions in their response and to increase public trust. All three of these examples have a similar thread in that they all took the opportunity to address the critical situation of the pandemic and had the foresight to plan for the long term. Taking that long-term view is particularly important today as we address the challenges of the current COVID vaccine rollout. The public health system has been put to the test, revealing years of neglect in funding and resources. Now is the time and opportunity to put in place the technology, infrastructure, and analytics for the public health system of the future. With the COVID-19 funding of today, public health organizations can improve the data and analytics systems of tomorrow, including the interoperability of systems and data, advancement of analytic maturity and approaches, combined with public health workflows and readiness. Your strategy should address immediate and long-term needs that reflect your unique circumstances. Optum is a partner in preparedness, prevention, and innovation. By delivering solutions across spectrums of health, we are focused on our aspiration of improving experiences and outcomes for everyone we serve while reducing the total cost of care. When we collaborate with visionary, motivated individuals like you, together we can tackle the biggest challenges in healthcare and accomplish results that move healthcare forward. Thank you.
Well, great. Thank you so much to our presenters. I'm having trouble coming off of coming onto video. It's saying that the host has stopped me. But I'll just talk because we can see our panelists, and that's the most important thing. Can you hear me?
Yes.
We can.
Good. There I am. Okay, good.
Hello.
Great. Great. So I'm monitoring our Q&A and chat function here to see if any of the audience has entered any questions. I don't see anything yet. So I did have a couple of questions I thought that we might engage in just as we're kind of warming up to hear from the audience. One of the things I wanted to start with is just a follow-up question. Well, first of all to Lisa, but then maybe to other members of the panel too, if you have thoughts. Lisa, I thought it was really, it's impressive that I think you said 92% of the population is covered by a health information exchange. But, I know that there are areas that we're really working on expanding participation in health exchanges and sort of penetration from other sectors that might bring data into that forum. So I wondered if you could speak a little bit about that, of, what some of the areas are that that your association is trying to grow the exchanges further, and what some of the approaches are that you're using or that those of us who are in the audience could do to help you in what we all want to see as a very successful endeavor.
Yeah, I mean, I think it's a great question. Obviously, the level of coverage varies in different regions, what that exactly means, what types of data are flowing, right? And I think, as I mentioned as well, HIEs really are very specific to their communities, regions, and states, and the preferences in those communities around how they want to share information. And, I think one of the most important things that we're seeing, through the pandemic in particular, is that we need stable sources of funding to build out these important public health use cases. And, again, we've seen in the most obvious way how critical they are, as you saw in all those examples, to those communities. And so we have this huge bucket of funding for data modernization and how that's actually playing out and what kind of guidance is available to states so they know what's actually possible. We still are missing a lot of that important guidance and a lot of that important stability around those sources of funding, because again, it's really about states partnering with the HIE in their community, region, or state, and figuring out, how to fund that over the longer term. The federal government has money, but they're missing sort of okay, where do we go from big chunk of money on the federal government side to getting to the states, and then also providing the states with the guidance about how to actually use it with other entities in their regions. And so that's really what it comes down to at this point. It's not the technology, we have the technology, it's about the partnerships, and it's about the governance in those local areas.
Great, thanks. And any of our other panelists have any thoughts about your experience with health information exchanges and how to expand and make that more robust?
I'd like to chime in. I think we ought to get strongly behind the CDC and its data modernization initiative. And as we heard at the opening of this conference, there are considerable funds for it. And the priorities include the National Notifiable Disease Surveillance System, making it more uniform nationwide, electronic case reporting, which is one of the CDC's top priorities and grew out of the digital bridge. There are HIEs already pursuing that. And then better syndromic surveillance, electronic vital record systems, better electronic lab reporting and lab information systems, and very important, the workforce to power all of these. Cerner is strongly behind that. I think we all need to get behind it. And I think not just federal, but state and local public health and partners will benefit as well.
Right, thanks. Mylynn, anything you want to add or? Can't hear you.
Are you on mute, Mylynn?
Maybe double muted, the classic. We're still not getting you.
Is there a command she needs to put in beyond taking the mute off? Well, we'll let you, if you want to work with her on that, maybe we can get her off mute so that we can hear from her. I'm going to move on to the second question. And actually, Amanda was just going back and forth to me. We do have 124 people in our audience, so there are folks out there, and we're waiting to see if we get some questions from them. But until then, the second question I wanted to ask the panelists, you know, as we're so focused now and we have such an opportunity to revolutionize and bring up to date the public health IT system. And, you know, one of the things that I found as I was listening to your presentations is just this question of, you know, what are the different roles here for really providing the leadership, providing the support, providing some of the governance. You know, what do you see as the different sectors doing? We have state government, obviously, who, for the most part, are the holders of the data, collectors of the data. We have the federal government that can provide such an important leadership role. And then we have the private sector who are bringing a lot of the modalities in to the equation for us to work with. What do you all see as, you know, the different roles that those different entities need to play to really make this successful? Bob, maybe I'll start with you as we're working on that.
I've led public health agencies, federal, state, and local, and we desperately need more uniformity and standards-based approaches and an overall system for surveillance with components, and agree to all adopt that over time. It's not going to happen immediately because we have so much variation at the state, among the states, and one state among the localities. And we all have to put aside all the historic differences and agree on common systems.
Yeah, and I would just add that I think, you know, I think that the federal government is definitely in its right to say, you know, here's a huge amount of funding and it comes with some strings, and those strings are you have to use certain standards and they have to be interoperable and you have to exchange it in this way. And if you don't want to do that, then, you know, you don't have to take those funds. I think that's okay. There has to be, of course, opportunities to onboard and technical assistance and, you know, time to meet those standards. But I think broadly speaking, that is an appropriate approach given what's in front of us and the challenges and pitfalls of huge buckets of money that have come our way in the past, right?
Yeah, that's good. It's sort of the stick and the carrot. It's a nice carrot if you want to participate. You know, here we have some serious significant resources, but there are some certain rules to the game. Mylynn, have we gotten you where you can speak with us? No, it doesn't seem to be the case.
I did see a couple of questions come in, Marcus, in the meantime.
Okay, and are you all trying to work with her to sort that out? I'm assuming she can hear us. Okay, well, I'm going to move on to one of these questions. How would you recommend state public health departments spend stimulus funds? Which of the provisions most excite you for help today and for tomorrow? Bob, we'll start with you again.
I would hope they could start with electronic case reporting, which again is one of the top priorities. It's not just one condition, COVID, it's all 90 plus conditions that are nationally notifiable, and invest in training, because our public health agencies are already short-staffed and we're going to need a lot of training and stabilization to make this happen.
Yeah, I would definitely second that. I mean, I think ECR and ELR, you know, electronic lab reporting, making sure that the labs are all connected. We've had a year in which to do this. It's obviously not that much time, but at this point, you know, there are still going to be probably for years, tons of labs who weren't really connected into the system before, public health labs, new labs that have been stood up. They need to be part of the system. And so that should be a really top priority for public health. And then I think really just, do you have your intelligence in front of you? Do you have the ability to track things like cases? Do you have the ability to see really complex population health analytics to show you what's going on in your communities? And then the one thing as well, which I mentioned, I think in my presentation, which I feel like is the canonical sort of public health HIA use case, where you say, okay, you've got all of this data coming in from many different settings, from a CVS, from a convention center, from a field hospital, you know, and can you actually enhance those point-to-point data with, you know, a longitudinal health record of a patient or of individuals or communities, so that you can get intelligence about what's really going on with, you know, demographics and ethnicity and race data, right? So that's really important. So are you getting that in one place where your public health decision makers, where your epidemiologists can really know what's going on in your communities? That's just critical. But I would agree with Bob. I think ACR should be right at the top of everyone's list if they're not there right now.
I would add that to achieve those kinds of analyses, analytics, and reporting and display, a public health agency needs access to a really good enterprise data warehouse and the analytic tools, often in partnership with the Medicaid agency, which has even more funding, of course, to partner to make that happen. And it so happens that Cerner and Optum both provide that, but there are many other vendors that also do it.
And Mylynn, have we succeeded in getting you where you can speak? Right now it says you're muted. I don't think so. Okay, we're going to go on to our next question. Lisa, we'll probably start with you on this one because it's about HIEs. So it says, HIEs have expressed reluctance in allowing access to HIPAA covered data by non-HIPAA covered public health agencies. Do you have suggestions on how to best overcome this reluctance?
Yeah, I mean, that really has not been my experience in all the cases I mentioned. We have HIEs who are actively and happily partnering and seeking out partnerships with public health. Certainly there are some, data use issues that exist. That's going to be the problem everywhere. But my experience over the last year, especially as, provisions of HIPAA have been loosened and relaxed for the pandemic, that has not been the case. If, the person who asked the question has specific examples or wants to follow up with me, I'd be happy to talk to them. But really what we're hearing on the ground is just a absolute willingness and interest in partnering and being part of the solution in the public health pandemic response.
Great. And sort of a related question I think you've hit on a little bit, but there are public concerns about confidentiality of any data, particularly when that data is in one centralized place. What are your thoughts about how you help overcome some of those concerns and help reassure people that their personal health data is secure in these vital surveillance initiatives?
Yeah, I mean, I think one of the best ways, if I can get on the soapbox for a second, would be to address patient matching in this country. Without, with the prohibition on even studying patient matching solutions at the federal level, we're in the situation where HIEs and other related entities, including EHRs, including other technology vendors, are trying to piece together information to figure out who's who. And then some of them do it better, some of them do it less good. And what really happens is that we end up sharing more data than we should. If we had better patient matching, we would share less data. And the principle of sharing the minimum necessary is kind of thwarted by the fact that we don't have a national patient identification strategy. So that's one thing. And then beyond that, most of the data is moving between HIPAA covered entities for those permitted purposes. And that's happening every day, just like normal.
Mylynn, should we try again? No, it doesn't look like it's coming through. Can you nod? You can hear me, right? Okay. As we continue on the questions, if you want to go into the chat, if you have any, sort of succinct points you want to make, go ahead and do that, and I can at least read some of those back out. We don't have any new questions from the audience. I do have another one that maybe, Mylynn, you can give us a few of your thoughts via the chat. But, I think all of you bring some perspective to this modernization of public health data from having worked in various ways with the healthcare setting and with the expansion of IT and modernization of the data systems there. And, I know that was not a seamless task either, but it is one where I think we made a lot of progress. And I just wonder from your experience with that, I mean, do you have any lessons you take away from that you could bring to the public health community? Maybe some things that were done well with that approach that are informative, or some mistakes that you don't want to see repeated. Bob, maybe we can start with you.
Sure. Well, I think public health, which does a lot of clinical services, should participate in electronic health records and in HIEs and be at the table with the medical care system. Many public health agencies, although they have clinics, are still on paper or on homegrown electronic health records and don't participate in HIE. So I think they need to be at the table and participating on the clinical side. It may be disease control, maternal and child health, immunizations, and so forth. When I was at the Florida Department of Health, we developed a statewide electronic health record, homegrown, on top of our billing and management, patient management system, got it certified nationally, and brought in more than $17 million in stimulus payments to the Florida Department of Health. Not many states did that, and now they're playing catch up to be at the table with clinical medicine. And as that happens, make it interoperable from the beginning. On the medical care side, that was done later, and rather than sooner. It should be part of the build.
Great. Lisa, you have some thoughts on this?
Nothing specifically to add there. I think there are some other interesting questions coming in, though. I'm not sure if we want to address any of them. They're quite varied.
No, I think there's a good one for you here. Let me just say, I do see that it looks like Mylynn's been successful in chatting in, and she made a comment that, you know, we should really come at this by never letting a crisis go to waste. This is a real opportunity that we have with the crisis that we're having, and not just with the pandemic, but, you know, also with the crisis that's queued up in our IT systems. And it's a good opportunity for us to really drive towards data systems that are really interoperable. And I think that is really that's what we're hoping to get at with the whole Tech Expo. So yeah, there was an interesting question from the audience. I'm going to read this out. It's a little bit of background here. I'm a medical director at the Puerto Rico Public Health Trust, a public health institution in Puerto Rico, and health and HIE is a large concern in implementation of both telemedicine and telehealth programs, as community stakeholders, both providers, points of care, patients, administrators, and institutions are all hesitant to participate in the HIE due to these same privacy issues and feeling vulnerable to participate as a result of that. So is there a tried and proven way to increase trust, participation, and overall buy-in with these initiatives? And I think, Lisa, we'll let you have a first shot at that.
Yeah, I mean, I can say quite honestly, there's not a single tried and proven way to increase trust, participation, and buying with these initiatives. But I mean, I think that, you know, really just digging into what's going on here, you know, why do people feel, is it just simply unfamiliarity with the platforms? Is there something else going on about, you know, the way health data is used in the territory? You know, I don't know for sure, but I think that over time, by piloting initiatives and showing, you know, the convenience and the appropriateness of telehealth and virtual care. I mean, I'm sure the other panelists agree that the pandemic has really shown the power and the limitations of telehealth and virtual care. I think we certainly don't feel like we can replace all, you know, care encounters with telehealth and virtual care. We can see a lot can be done through these medium, and it's really wonderful. So giving people a chance to experience that and really have, it's kind of like with you know, vaccine distribution and overcoming vaccine hesitancy. Once you see other people using it, once you have that first experience, a lot of that goes away, and that fear is replaced by, wow, I feel so great that I didn't have to go and drive and wait in traffic and park, and I could, you know, get this encounter taken care of and get the healthcare I need. So it's really just a matter of time and proving it out, and you know, starting small in my experience. And then just one little plug for HIEs here, I would say that we think it's really important to combine the expansion of telehealth and virtual care with an expansion of information sharing and making sure that virtual care providers have access to the longitudinal patient record. That is a critical piece of making those encounters good and safe and useful for everyone involved.
And Mylynn has weighed in the chat, mentioning that, sort of reinforcing what you're saying, that increased transparency and communication is what she's really seen help build trust in systems like this. And that also helps bring more, it also helps to bring more people to the table to build that trust. I think we have 1 minute left. I'm going to end with a question that I think you've both spoken to a little bit, but Mylynn can also type in if she wants. So you have been suddenly transformed to tomorrow. You're transformed into a role where you are a state public health director, and you're sitting in a position where you have substantial financial resources that we're all seeing going out into states. So what's the first thing you're going to do with those resources, as far as, you know, the most meaningful thing you think you could act on to really start to bring the public health information technology system where it needs to be? Bob, let's start with you.
Well, this would be a pleasant surprise to have that kind of resources. If I did this again, I would really invest in training, because we need to train the people who are there better and provide training to those we recruit, so we have a better chance of them getting up to speed fast. And I would, of course, focus on technology and other infrastructure.
Excellent. Lisa?
Yeah, I mean, I think we need common rules of the road for health information exchange. It's certainly a proposal that many folks will be familiar with, TEFCA. It hasn't come to fruition yet, but that common contract, those common rules of the road is, I think, really the next step for moving the industry forward.
Great. And I will close out by reading Mylynn's comment, which I think for our audience is probably something they're going to be really happy to hear, because I know that many people in our audience are public health professionals. And so Mylynn said, number one, give public health resources a raise. And I think that really is a very important thing. We need to invest in our workforce. We also need to bring up the standards of our resource, where bring up the standards where the people who work in public health really are, you know, getting the kind of rewards that many other people, we get rewards in public health for many things, but it would be nice if we could make some of our positions more competitive. And then Mylynn also mentioned that you're getting the right technology and experts, and it helps really make that investment effective. So we are a little beyond our 45-minute time. I'm sorry we ran over, but I want to thank again our panelists for an excellent job. Mylynn, I'm so sorry about the technical problems, but at least we got to see you. So thank you for that. And thank you all for your video presentations that you worked on so much leading up to this. We're really grateful that you were willing to help us make this event such a success. Thanks very much. Goodbye.
Thank you.
Okay, Matt, are we off the hook now?
Yeah, I was just told to leave this up for a couple of minutes.
Okay, and if we want to go on to the plenary, we should go back into the other portal, right?
Yeah, exactly.
Okay, thanks everybody, and thanks for all the support.
Good work, Marcus, and see you later.
Yeah, thanks, Bob. Good to meet you over this venue.